Okay, welcome back, everybody. Hopefully, that's everybody back and had another stretch and move about and ready for the last speaker of the afternoon. So we have with us John Gasenica. Hopefully I've said that right. That was me practicing and potentially still getting it wrong, so I apologise. John is currently with us at 7 a.m. his time. He is coming, joining us from LA this afternoon for us. And has kindly agreed to speak for us. John is a psychotherapist and a coach and a host of the Pain Reprocessing Therapy podcast. John serves as the Director of Clinical Research and Development at the Pain Psychology Centre in Los Angeles, California, where he teams up with medical schools, healthcare companies, and government agencies to conduct research and improve the treatment of chronic conditions with psychology. And he's going to speak to us about pain reprocessing therapy this afternoon. So I'll hand over to yourself, John. Thank you.
Great. Thanks, Claire. Let me share the slides. All right, so hopefully that's sharing. Um,
Yes.
Nice to meet everybody. Is that working okay, Claire?
It is, yes. Thanks.
Great, thanks. So I am here to talk about pain reprocessing therapy and really kind of a new wave of uh, additional pain therapies as well. Just a brief introduction. My name is John Gasenica. As Claire was saying, I'm the Director of Clinical Research and Development. I spend most of my time these days seeing patients in clinical trials, practicing pain reprocessing therapy, and trying to validate it for different um, pains in different parts of the body. And so, if you're not familiar, pain reprocessing therapy is it's just a system of psychological techniques, and the aim is actually not to cope with chronic pain. Its aim is to actually eliminate chronic pain. And it's based on neuroscience, particularly neuroscience coming from fMRI research the last 20, 25 years that shows that the majority of chronic pain syndromes and symptoms are a neurology issue. It's misfiring of neurology rather than issues with the physical body. And if this seems kind of wild to think about, I can hopefully show some data today to help change your mind. And so it's a pretty basic treatment. It kind of is three different wings. First is pain psychoeducation, and this is probably the most important, as we'll show with some of the data later, is actually teaching the patient that they are not physically broken, giving them all the type of data and studies in the last 10 years to show that this is actually a neurology issue they're dealing with for the majority of the time. Second wing of the treatment is getting corrective experience. So these are exposure exercises. This is meditations. It's actually helping the patient get into a very, very deep sense of relaxation and watch their symptoms actually change in real time to help get evidence that they actually are okay, that this is a neurology issue. And the third wing is decreasing fear. So it's not just decreasing fear of the symptoms, but it's also decreasing fear in the other aspects of the patient's lives. So these are patients who have trauma, patients who have personality disorders or anxiety disorders. It's teaching them how to regulate their nervous systems more consistently so that they can increase their neuroplasticity, increase their sense of safety, and actually teach their brain this new way of thinking, which is to essentially ignore the benign signals coming in from the periphery rather than amplify them, which is what chronic pain is. So in our first study, we had about 150 people with chronic back pain. Um, and it was a very exciting study because nearly everybody got better and some people got drastically better. This is the first study where they actually had a category for people who were completely out of pain. And as you can see, two-thirds of participants were in that category of out of pain or nearly out of pain. Um, and this was after 8 sessions of treatment. So it was about a 4-week protocol. And one of the really kind of interesting pieces of this study is that there was three groups of people. Some people got PRT, 50 people got care as usual, so just their normal PM&R doctor, and another 50 people got an open label placebo and were told it was open label. So they were essentially said, we're going to inject you with saline into your back. It's completely benign. There's no curative properties to the saline. And actually, a percentage of these people had a complete decrease in chronic pain. And so, not quite as much as the PRT wing, but it also helps to show that something like an open label placebo, how powerful that is for people's psychology. Um, Even when they know it's not supposed to do anything, just the act of getting touched by a doctor and have them put a needle into you can sometimes convince the unconscious brain that you're getting some sort of treatment and then you're going to be okay. And so, some important things about patients in this study. This is, the big kind of point of contention with many patients is they say, I actually am physically broken. I have MRIs. As Dr. Sarno, one of the trailblazers in this industry, used to say, most people's findings, particularly spinal MRIs, are what he calls normal abnormalities. And this study showed that patients average four spinal anomalies. So that includes spinal stenosis, slip discs. Um, Even this X-ray from a patient in the study, if you can see with my cursor, her spine looks like a question mark. This is scoliosis at a pretty significant angle. This patient came into the study with significant back pain. If you were to look at her MRI, you would say, oh, well, of course she has back pain. Well, she was in that category of pain-free or nearly pain-free at the end of 4 weeks. And so we know that changing somebody's neurology through a psychology intervention can be quite powerful, despite somebody having some significant uh, abnormalities on their MRI. And so this was an fMRI study. So every patient got put into an fMRI machine before and after treatment. And what we found from the treatment afterwards is that patients essentially had less reactive brains to external stimuli. So before the treatment, if they were invoked with pain, I believe it was a hot prod, we could read how much their brain is reacting to the external stimuli. And after the study, they found that these regions of the brain that light up with evoked pain activity actually decreased. And this is one of the exciting things about these type of therapies is that it's not just the pain that decreases, it's the patient's reactivity to pretty much any external stimuli. And so this is stressors in their lives. This is sound sensitivity, smell sensitivity, their consistency of getting things like rashes or stomach ailments. If we can give our patients an opportunity to decrease their reactivity to stimuli, essentially building their resilience, it can be a very exciting and rewarding process. Um, Now, there was a couple shortcomings to that study. One of the big criticisms is that it took place in the town of Boulder, Colorado, which is primarily a middle to upper class community, particularly white community. So there wasn't a tremendous amount of diversity, both ethnic diversity, financial diversity, and ACE score diversity. And so this kind of started a wave of different research studies to show that we have external validity with pain reprocessing therapy. So this May, we are starting a study with the Mount Sinai Hospital program in New York. This is really exciting because it's going to be one of the first studies that actually the outcomes are going to be somebody's pain scores. But then another thing we're looking at is how much cost savings would a psychological intervention do for a hospital system. In our country, the insurance companies are very, very interested in their cost savings. And so if you can tailor your research to show them that something like a psychological treatment can help save an insurance company on steroid injections, physical therapy, surgeries, this could be quite significant. And then about 3 years ago, we started a study testing PRT on racially and ethnically and actually age diverse population chronic back pain. I've been doing this study for 3 years now. I'm excited to announce that we end the study probably in the next 4 or 5 weeks. I think we've randomized 147 out of 150 participants. And so the whole point of that study was to prove PRT's efficacy with people of different trauma backgrounds, ethnic backgrounds, financial backgrounds. On top of that, There are several more studies starting with pain reprocessing therapy. This year, there's one on post-surgical knee pain. There's one starting on pelvic pain. There's going to be one with fibromyalgia, which actually is a brain fMRI study, which is a little bit more of an expensive study. And we are studying, we have formed a uh, study with the Veterans Association, which is going to be 360 veterans receiving PRT, which is a great study to do because, as I'm sure you're all aware, veterans have quite a significant amount of ACEs and trauma, and to show that PRT works in that population will be a very helpful study for the movement. So I want to talk about, because we only have one published study on PRT and some studies, some follow-up studies, like we have the 5-year follow-up study coming out this year, which shows that the results stayed consistent. I want to talk about some of the other similar treatments that have been researched to add to the scientific basis. So PSRT, this was a treatment that was developed by a practitioner named Mike Danino out of Harvard University. And so far, the studies he's done with PSRT have been really promising. With back pain, you can see is 63% pain-free rate after 26 weeks. So it's a little bit longer of a treatment, but still significant decreases in pain. And then really exciting treatment he started was a study on long COVID. And so the long COVID study was a little bit more limited than the chronic back pain study. But again, you see a 55% decrease in long COVID due to psychological treatments. Um, and people are starting to take notice to some of these numbers. The other treatment I want to talk about, which was created by a colleague of mine, Dr. Howard Schubner, and a partner of his, Mark Lumley, is EAET, so emotional acceptance and expression therapy, emotional awareness and therapy. And so EAET really takes into account more of people's emotional experience. So the theory behind EAET is emotional repression and suppression, and a fear of emotions on mostly an unconscious level leads to a significant activation of the nervous system. And so EAET focuses on decreasing people's fear of their emotions, increasing their expression and awareness, and increasing connection and a sense of agency in the population. This is a particularly exciting therapy because I think it really helps the therapy I practice, PRT, in that it adds the emotional component, more of the emotional component than PRT focuses on. They compared EAET versus CBT in older veterans. And again, we do a lot of studies on veterans because it helps practice the treatment on a population that has a significant trauma load, not just trauma, not just PTSD from their military experience, but their significant trauma in the military community even before they enrolled in the military. And so the importance of this study is just the comparison of EAT with CBT. Now, this is not a criticism of CBT. In fact, PRT and a lot of EAT principles, even though EAT is kind of a psychodynamic based treatment, has a lot of similarities with CBT. We'll talk about what differs between CBT and some of these treatments and some of the things that CBT practitioners can include in their treatment. I personally was trained in CBT before I even got into PRT, and I think there's a lot of overlap and a lot of skills that are complementary. But the helpful thing about these studies is it's showing consistently that EAT is outperforming CBT. There's been a bunch of different things they've tried with whether it's fibromyalgia or chronic back pain. The study that I'm currently involved in that will get published hopefully this year compares PRT with CBT as well. And so I want to talk a little bit about what CBT, mindfulness, ACT, some of these therapies are missing. We know through the extensive systematic reviews and literature reviews that CBT and mindfulness, they do really well on decreasing anxiety surrounding pain, decreasing somebody's depression around their pain. But the actual effect on the pain scores themselves are pretty limited. In this systematic review, at least on 52 CBT studies and 11 mindfulness-based therapy studies, there was limited no effect on pain. And there's some studies you can find where pain is changed a little bit differently. But on the whole, CBT has come up a little short with actually changing the pain levels. And the theory behind this of these new waves of therapies is that this aim of CBT or the aim of ACT has really been to decrease the suffering caused by pain rather than help convince the patient that the pain doesn't need to be there. And over the years, we've received a lot of comments from clinicians and physicians that they don't want to tell their patients that the pain is all in their head. And the one thing I want to be very clear with today is that none of these treatments are telling the patient that the pain is all in their head, that they're making this up, that there's a weakness or a perceived benefit to the pain. But what we want to start teaching the patients is how to educate themselves to figure out, is this sensation that they're feeling, is this an issue with their neurology, or is this an issue with their physical biology? And there's been some really exciting research coming up to help point our patients in the right way. This was a study done by my colleague, Howard Schubner. He went to a physical medicine clinic in Louisiana. And out of 222 patients coming in, typically for back aches, neck aches, when he taught the doctors in this clinic how to actually look for what we call neuroplastic pain, or in what in the research calls primary pain, after a short training, the doctors were able to spot this quite quickly. And what they find is that out of 222 patients, 88% had primary pain. So essentially neuroplastic pain that's caused by neurology rather than a physical anomaly in the body. And so what this tells us is that if doctors can start getting trained more on spotting this, our patients will start to be notified that their pain issues are not going to be fixed by surgeries. They're not going to be fixed primarily by injections or even physical therapy. There's going to be a psychological component to alter the neurology that they're going to have to address. And as you can see in this study, 97% of these patients had at least one anomaly on their imaging. And so these are back slips, these are our spinal slips, these are spinal stenosis, this is scoliosis. The chart I included in the right is just some commonalities in the patients who were diagnosed with primary pain. And you can start to get a sense of some of the commonalities in people who have neuroplastic pain. So this is pain that varies during the day. That's probably the most important component to helping a patient realize that their pain is coming from a brain process. Stuff like worsening at night or spreading through the body. Mirrored symptoms are a fantastic sign of neuroplastic pain. There's very rare physical processes that can actually cause pain in both your hands or both your ankles or both sides of your back. And so the more research that comes out that shows people conclusively that their pain is coming from the neurology, the easier it's going to be to help patients to get on board with this idea that they're going to be okay. And the reason I emphasize this idea of reattributing your belief of where your pain is coming from is some of the research we got from our Boulder back pain study. On the right is a chart of all the things that people attributed their pain to before they started treatment. So if you look at PRT pre-treatment, a ton of the attributions that the patients had to their pain were injury or activity, sedentary, I sit all day, I'm on the computer all day. They need to work on their physical health, their physio health, or they just simply believe that because they're so old, they're going to have pain. You can see in the pre-treatment, the majority of their attributions to where their pain was coming from came from a physical place. Now you can see in PRT post-treatment, this changes pretty radically. A huge chunk of the patients start believing my pain is coming from my psychology. It's coming from my brain. As you can see, these green segments here It's coming from a stress component. When patients start attributing their pain to psychological processes and actually start working on soothing their nervous system, this has a huge significant component to them getting better. And in the post-treatment analysis of why people got better in some of these studies, what they find consistently are three main factors of why people are getting better. The first is this idea of reattribution of pain. People are starting to believe I am not physically broken. This is the, if I'm using CBT language, this is the huge distortion that causes a tremendous amount of fear in the brain that doesn't allow somebody to actually get better. If you believe that slip disc in your back is what's causing your pain, it's really hard to believe that you're going to be okay. I'll talk about why this is so important, this reattribution, in a slide from now. But as you can see in the other wings of the study, usually the usual care or the placebo treatment, people's belief about where their pain was coming from largely stayed the same. And if you compare the data of people who got better with PRT versus people who got better with usual care and placebo, there's a significant component due to attribution. Now, the two other factors we've found in the research that do um, help people get out of pain or some commonalities in people who do get better with these studies. The second one is an attribution to pain not only away from the physical body, but realizing how much stress causes nervous system activation and how much that leads to chronic pain. And particularly in this case, emotional dysregulation. Somebody has dysregulation around fear, if they have dysregulation around sadness or anger, how much of that contributes to the pain. So the patients who really focused on not only regulating their systems in terms of stress, but regulating their systems when it comes to emotions coming up, got better quickly. And then finally, the third thing that people had in common in terms of people who got better is this connection with the clinician or connection with other people. So if there was a really good connection with the clinician that was giving treatment, or if the person started connecting more with their community during treatment, they got better quicker than those who didn't. Um, and this goes into this idea, this theory of the more perceived safety you have, the more your brain is able to start properly reading signals through your body in a lens of safety and turn these pain signals off. And so a lot of the work I do on these studies, I have 8 sessions with a patient and kind of the clock's ticking, you want to get them better, but a significant portion of my treatment with patients is just chatting with them, talking about how difficult this has been, learning about the different aspects of their life that are affected by their pain. So that the patient feels like they're being heard, understood, and they're connecting to me. This is almost more important than anything I do in these trials. And just I'll go through this quickly, but just some stats to help change your patient's brain on where their pain is coming from. These asymptomatic studies are really interesting. So in asymptomatic studies, you put a bunch of healthy people in an MRI machine and see, do they have spinal anomalies? You can see on this chart on the left, if you're a healthy person with no pain, say in your 40s, there's a 68% chance that you're going to find some sort of disc degeneration on your MRI. Disc height loss, disc bulging, even facet degeneration. This just shows how prevalent it is for people to have anomalies in their spine, but have no pain at all. So what I like to start to do with my patients is tell them there's a substantial portion of the population who has exactly what you have on your MRI, but doesn't have pain. All we have to change is the way that your neurology is working so that you can enter this population who has the normal wear and tear of life. And a doctor on our medical board talks about these changes on MRIs as like gray hairs of the spine or gray hairs of the back. I started growing gray, I think, in my late 20s, but it wasn't painful on a physical level. Psychologically, it might have been painful for me to turn gray in my 20s, but it didn't have to be physically painful. And this is not just with spines and necks. This is across the board with knees and shoulders. A tremendous amount of patients we treat at the Pain Psychology Center come in with labral tears and meniscus tears and high-grade tendonitis. There's a huge portion of our population who have these tears in their body and don't even know it. They'll go in for an MRI for something different and they'll find out, wow, I have a meniscus tear. And so stats like this and studies like this really help our patients start to learn, okay, just because there's something physically abnormal about my body does not mean I have to have decades of chronic pain. And so I usually show this slide to my patients to help them realize how their brain is actually changing their body or changing their awareness of pain. If you look at this slide, I want you to look at the center of the slide, the black dot, and just notice if that black dot in the middle of the slide is changing, if it's growing, if it's increasing. What we know is about 80% of the population sees this optical illusion and sees some form of that blackness increasing. What's happening here is that your brain is using a process called predictive coding. Your brain has seen something that looks like this before. This looks like you're going into a dark tunnel. And so what happens is your brain predicts in a few seconds, things are going to get very dark. It looks like I'm going into a dark room. And so the reason that black blob in the middle of the screen increases or gives you that optical illusion is actually your pupil is changing. Your pupil is dilating to let more light in because your brain thinks you're about to enter a darker room, even though, as we know, things are not getting darker. And so this is a great example of something called predictive coding. And it's one of the things I like to explain to my patients before treatment is that our experience at any given point is a combination between the peripheral nerve information coming in from our body. So in that last slide, the information coming in from my eyes, my optical nerves, and it's a combination with what my brain predicts is about to happen to me. And so if you see this slide, these are some great theoretical psychologists who mapped the way the brain actually gives our pain perception. And it's very like machine learning in that the brain takes in this blue blob on the left. This is everything coming in from your periphery. Your brain takes in about 6 million pieces of information a second. And on the right is this yellow blob. This is your brain's prediction based on your prior experiences and your beliefs. And what it does is it combines the prediction and the nociceptive signals into your pain perception. And so what we've found with the research is that people who have been in chronic pain or have persistent stress and anxiety, their nociceptive prediction becomes a larger component of their pain perception, essentially meaning what their brain predicts is about to happen to them has a more powerful effect on what they actually feel. And so what we can do is actually manipulate this prediction. When somebody starts predicting, I am not broken, I don't need to have pain, or I am not anxious right now, or I am not in danger, their brain starts predicting more and more. I don't need to have pain just because of what these nociceptive signals are showing me. People in these charts previously who have anomalies in their spines, their knees, or their shoulders, but don't have pain, their brains have maintained this ability to protect or to predict that they're going to be okay, which is why their pain perception goes down to zero, even though they have significant nociceptive signals. There's been some really interesting research about the commonalities between uh, sensitivity, noise sensitivity, sound sensitivity, taste sensitivity with people in chronic pain. If you have these type of sensitivities, you're much more likely, 2 to 3 times more likely to have chronic pain, and vice versa. What this is telling us is that a brain gets used to predicting danger consistently, and this is why people start to feel more and more sensations. And so I meet with a lot of doctors, and a lot of doctors are hesitant to talk to their patients about this because they don't want to gaslight their patients or convince them that it's all in their head. So usually I like to talk a little bit about a 30-second pitch that you can tell your patients and then give them some research. Number one point here is the absolute most important point is that your pain is real. Your brain's pain signals are going to feel the same whether it's from a benign nociceptive signal or from a nociceptive signal that says you have significant damage. But pain is not necessarily a sign that you're injured, even though it feels this way. Second point, you can start talking about some of the research that your brain might have developed a habit of believing or predicting that you're in danger. And an important thing here is to keep it on the unconscious. You're not intentionally doing this. Your brain does this without your awareness. A lot of people are affected by this. In fact, everybody is affected by their brain predicting something that's not there. This happens hundreds of times a day. It's just on different levels. This is not your fault. This is often a process that came about because of trauma, came about because of an injury, came about from a significant period or lifetime of stress. And you can get better. The more research we do and see how this is externally validated to people of all walks of life, particularly those with significant trauma, uh, we like to tell our patients you can get better. So finally, if you're interested in any of these therapies, um, I run a podcast called the Pain Reprocessing Therapy Podcast, where in each episode, I will show a segment from an actual treatment session I've done with a patient and talk about some of the techniques that I'm using. A great resource is The Way Out by Alan Gordon. He's the creator of pain reprocessing therapy. And then you can also check out pretty much anything that Howard Schubner has done. He's kind of the leader in a lot of the research on this. And then finally, if you have any questions or thoughts or comments, don't hesitate to reach out to me at John G Therapy. Um, and I'm always happy to talk about some of these concepts. But I am hoping to open up the floor now to question and answer. Claire, is the timing okay on that?
Perfect. Thank you so much for that. That was great, really interesting, informative. Thank you. Um, I suppose it sounds like there's a lot more research being done. It sounds like there's recognition that further research is required to kind of embed and evidence that further relating to pain reprocessing therapy. I was wondering, in terms of what evidence or findings that there are for maintaining the improvements. You said even that Boulder study that after 4 weeks there was significant improvements noted in a lot of the participants. Is there information on what happens after the treatment sessions are completed, how long that has lasted, has that kind of pain improvement been maintained, or with other life stressors, if given the history of some of the patients or the participants, is there any kind of evidence of how that is maintained and how the benefits are maintained for participants or people who've used pain reprocessing therapy?
Yeah, so they published a 1 year follow-up study. Dr. Yoni Ashar published it, and the results maintained at 1 year. And actually, what's really exciting is I think in the next month they're publishing the 5 year follow-up. And we had a meeting with Dr. Yoni Ashar last Wednesday, and the results maintained over 5 years as well. So this was a really important finding to make sure that these results are holding throughout.
Thank you. And there's some more questions coming in now in the Q&A, if anybody else wants to ask any more. So Anna's asking, saying thanks for the talk. I wonder, how do you select who PRT is appropriate for?
So we have in the book the Way Out, Alan does a really good job of coming up with like 10 questions to ask your patients on who is appropriate for pain reprocessing therapy. So some of these questions will be, does the pain move around? Is the quality of the pain different? Have you had periods during the day or at night where the pain actually goes away? Does the pain move from side to side? Is it mirrored? Is it in both hands, both shoulders? There's a sequence of questions we go through that helps us not definitively diagnose neuroplastic pain. I usually rely on a doctor like Dr. Howard Schubner to do a full assessment, but it gives you a really, really good idea and your patient a really, really good idea on whether it's neuroplastic or not. And the most important thing is that they start to build this confidence that they're appropriate. I've never had a patient start this treatment who 100% believes what I'm saying at the start. They typically need to do some of the meditations to actually feel the pain start to shift and change. But once you do a meditation with a patient, and let's say they're on the fence, I'm not sure if this is structural, I'm not sure if this is physical, and they do a meditation and the pain actually moves from the bottom of their spine up to the top of the spine, but the MRI shows that the damage is in the bottom of the spine. It's very hard for them to walk away from that experience without some sort of belief that this might be due to my neurology. There's nothing really going on in my spine that could actually transfer the pain from the lower spine to the upper spine. Um, and so those are some of the things we do to help increase the patient's belief in neuroplastic pain.
Thank you. So there's another question. It's really important we provide our patients hope, and the pain science tells us that. But are we at risk of rebranding graded exposure, DIMS and SIMS, experiential pain understanding?
I'm curious in terms of the risk of rebranding. This is if patients are interested in this. Yes, this is definitely a just a rebrand of graded exposure. I'm not sure what DIMS and SIMS are, or experiential pain understanding. I always like to explain to patients that a lot of these methodologies have been around since, some of these methodologies have been around since the 30s. Um, and so I give them kind of a theoretical background of where this is coming from. Um, and so I'm be curious if people are able to kind of speak up and give some clarification on, I'm not sure if I understand the risk of rebranding graded exposure, if you could explain that a little thoroughly.
We could invite them to speak, but it was an anonymous question, so I'm not sure how
Got
they
it.
presented that one. And just for the record, DIMS is dangers in me, and SIMS is safeties in me. So it is a lot of, as you say, the historical approaches that you've drawn upon for this to develop.
Yeah, I've been kind of allergic to some of the rebranding terminology that people have used. It's like you're essentially just saying mindfulness in a fancy new language. Um, Over the years, what I've found is that sometimes things having a very specific name and title and brand give the patient a feeling of legitimacy, and it actually increases safety. They say, like, I'm doing this very specific protocol that has very specific titles and has been very specifically thought about. So it's kind of cut down on some of my revulsion to some of the rebranding, as I've seen it in patients really kind of buy into, like they really buy into a term for something, and they say this is legitimate and this has been created by somebody and studied. So I understand the feeling of, gosh, this is just kind of repackaged something else. Um, but I have found it to be really successful for people to feel like they have a very specific structure and protocol that has very specific titles.
Thank you. So Barbara Phipps says, thank you so much, Dawn, for a great presentation. I'm trained in PRT and use it with my groups and individuals and find it really useful with some very positive results. A real game changer and gives such hope to people. And then we've got another question. Thank you, John. Do you know of any resources that can support this discussion with people who are neurodivergent?
It's a great question. We have in the study that I'm currently working on, we have had a quite a few people on the autism spectrum in the study, but I don't know of any resources of any clinicians who specifically have podcasts or any writings based on the neurodivergent community. So if something comes up, I'd be happy to share it on LinkedIn or Instagram, but I'm not aware of any resources right now.
Sounds like it might be a great topic for your podcast, that one, John,
For,
if you get the right speaker.
absolutely, yeah, the right patient, exactly.
Thank you. I wonder as well, just a question of my own, often people with persistent pain or pain that we see within our pain clinics have comorbidities as well. So how does PRT link with the wider, we've heard today about those kind of other supported self-management for long-term conditions, other healthcare treatments. We've heard about lifestyle medicine today. How does it link in, or what has your experience been for linking that in with the other impacts that people may have in relation to their pain?
Yeah, I mean the one big comorbidity I'll talk about is PTSD, and this is where that treatment I was speaking about, EAT, can be very, very helpful. Um, the emotional reprocessing they do in EAT, I think, is unbelievable. And in my treatment with veterans who are suffering from significant PRT or significant PTSD, um, getting the level of fear down from their PTSD before you even start the PRT can be incredibly helpful. This has been probably my biggest finding of the research that I've been involved in the last 3 years is before I even start anything with the pain, if I can get somebody better regulated just in their daily stressors or their daily anxiety, um, spend 3 or 4 of my sessions doing that, when we go into the PRT work, it really amplifies how quickly they can get better. Now, with some of the other comorbidities, some of the immune uh, diagnoses that come up, where there are some things like rheumatoid arthritis. PRT can't eliminate all pain from something like that, where you have an actual immune dysfunction going on. What we found is that there is a significant component of these immune disorders that is neuroplastic. So just being open with the patient, letting them know, I'm not going to be able to change your biology on these issues, but there are certain ways your brain is amplifying your flare-ups of RA, or it's amplifying some of your other immune flare-ups. And if we can turn the volume knob down 30, 40%, and all of a sudden your flare-ups, you can still take care of your kids when you're in a flare-up, or you can still go back to work or still do whatever you want to do while you're in a flare-up, your fear of these flare-ups is going to go down significantly. So it's really just communicating what PRT can do and what it can't do. And then there are certain circumstances where we cannot change the actual structural component. But in most structurally caused chronic pain, there is a neurological amplification of the symptoms that PRT can take care of. And sometimes that's the difference between holding a job and not holding a job. Or sometimes that's the difference between being able to have children, being able to have a relationship or not. And if we can put somebody in that category where they have a more functional, fulfilling life, then that's our goal for PRT with those type of conditions.
Thank you. I think Chris has got his hand up with a question.
Yeah, I could ask about 50 questions, John, but I'm going to pick maybe just a couple. I think when this was emerging as a practice in all its different iterations, like the initial claims by Sarno, for example, it was quite easy for the broader medical world to dismiss that because it was just, well, where's the evidence? This is one person's opinion, etc. But now it's becoming increasingly backed by evidence. It's becoming unignorable, and yet it's still a siloed practice, particularly in, I guess, the UK. You mentioned insurers are on board, so the money is on board, which is always important in any paradigm shift that we're trying to work on. So what therefore are the biggest barriers to this becoming quickly mainstream? To me, it sounds like it's us clinicians clinging on to our old ways. Would you agree with that?
Yeah, clinicians, I think public perception, a lot of people just don't know this exists. I'd say like 1% of people in chronic pain realize that they can actually use psychological treatments for it sustainably. Part of this is the studies on the old therapies have just showed that they haven't really been effective. Um, and I think these type of paradigm shifts take a long period. I think one of the things we find most is it's really, really helpful. And most of the studies we do, we have a physician see the patient first, and the physician conclusively gives them this idea, you are not broken. And it gives them this wave of confidence going into it. If you can get doctors on board with this, and the biggest pushback we have from doctors is, I'm so afraid I'm going to really offend my patient. They're going to be really offended when I tell them, hey, you've been trying to treat this physically for 15 years, but that's actually not been the correct way of doing this. This is actually a neurological issue. The more doctors we train, the more experiences they have where people actually find a significant amount of relief when they're told you don't have to do that third back surgery, or you can actually treat this psychologically. So I think one of the biggest barriers is one, training physicians that this is something that they can actually treat their clients with. Um, and then two, getting physicians on board with presenting this information to their patients. One of the biggest feedbacks we get from physicians we train is, I have all these patients with chronic symptoms, and physicians will admit it. They're my least favorite patients because I can't help them. And they get frustrated with me. I feel like I'm not doing my job. And just the idea that they now have a resource to push the patient to. They don't even have to deal with the patient. They can say, go talk to these people. They'll help you out. Is a significant sense of relief. So I think educating physicians is probably the number one focus that I want to have on spreading this. And then just scaling this with clinicians. So just training people on how to do this. There's been some great studies on exposure therapy. At least in America, 30% of clinicians use exposure therapy, even though it's unbelievably successful for PTSD, anxiety, things like chronic pain. And when they ask clinicians why in these studies, it makes clinicians uncomfortable to push their patients towards something that's uncomfortable. The clinician doesn't want to do it. It's a lot easier to work on soothing methods. It's a lot easier to talk about childhood traumas than actually have your patient look at the pain in the face and actually try to reprocess it. And so once we get through the physicians to let them know, okay, we want you to educate your patients, it's really also convincing clinicians that this is safe. You can actually do an exposure activity with your patient. You're not going to re-traumatize them. You're not going to cause significant more anxiety, and that this is effective. So I would say those are kind of like the two main barriers right now to mass acceptance and mass use of these treatments.
Yeah, no, I agree.
I'm going to stop your next questions, Chris, because I know you'll have many more, but that's our time up. We've also got a few comments just in the Q&A about, I think Anna says, I think the biggest thing holding back a wider adoption of, I think that's PRT in the UK, is the small evidence base. So it's great to hear that more is planned. And then we're getting more. Somebody else is saying perhaps it's also important to get surgeons to admit they can't always fix people and therefore not get people's expectations up and more confused. And Barbara says, I feel physicians and other clinicians are stuck in the biomedical model, which is understandable because that's how we are still trained. But when you adopt a holistic approach using things like PRT, you can realise that things can get better and people can improve. And this is much more rewarding as a clinician and for the patients. Changing medical practice is a slow process. And I suppose, again, we've had discussions about that wider MDT today and how that can be used rather than getting away from the medical model and the biopsychosocial approach that we would recommend for pain management. So thank you very much, John, for your time this afternoon or this morning where you are. That's great that you got up so early to speak to us, and we really, really appreciate it.
Sure thing.
Thank you. So that's the end of our speakers for the day.